Good morning, everyone. My name's Roberto Pineda, and I'm a associate professor of ophthalmology at Harvard Medical School. I'm going to be talking to you today about refractive cataract surgery with new technology, IOLs, getting it right the first time. Um, these are my disclosures, which are not relevant to today's topics. So this is a very important discussion because today our patients want the best visual outcomes. Uh, Modern cataract surgery really has become refractive surgery, and preoperative cataract evaluation has become much more involved. There's more decisions, more choices for both the doctor and patient with types of IOLs as well as new technologies such as femto laser assisted cataract surgery. So the expectations are higher for both the doctors and the patients, and there's money involved, which is always an issue. And so that makes it potentially a nightmare for some patients, for some surgeons. So it's important to be prepared, as if you're not, you're going to fail. And that means that the preoperative preparation for two technology IOLs means really understanding the patient's needs and expectations. And that means actually talking to the patient and spending more time understanding their lifestyle and desires, what their occupation is or recreational needs are. And we have to also screen patients for specific eye problems such as blepharitis, dry eye, corneal irregularities or opacities. Pupil size becomes very important, as well as macular pathology. And that means additional testing. It's almost like doing a refractive surgery workup. We have to look at eye dominance. We have to measure Schirmer's tear breakup time. We possibly need to get macular OCT. Corneal topography is necessary. We need to measure scotopic pupil size. And obviously, aberrometry and optical biometry are essential. So we also need to find out if patients are contact lens wearers and how successful that was for them. So this is just an example where corneal topography has essentially become essential for new technology IOLs. We have to look at the Myers, we have to determine angle kappa, we have to look at the amount of astigmatism they have, we have to look at corneal aberrometry, as I mentioned earlier, and pupil size, whether it's very large or very small, because they all have implications with new technology IOLs. And so looks can be deceiving, and we have to pay attention to the details. And it really starts by understanding our ability to hit the target, so to speak. And really, this study by Warren Hill of over 250,000 people show that we, get it right about 70% of the time being within a half a diopter and 90% of the time being within one diopter. And only 1% of us get it right 90% of the time within a half a diopter. So we're really looking at a range of around 60 to 75% getting it right. This is a more recent study using swept source OCT, the IOL Master 700, and using a new IOL formula, the Barrett Universal 2, which achieved almost 80% within a half a diopter. So let's talk about new technology IOLs. You need to get it right. It needs to be near perfection, just like Simone Biles here. And most of us, that means a lot of time and energy into doing that. And I want to first talk about extended depth of focus lenses. This is really one of the newest technologies that's been introduced for presbyopic correcting IOLs. And basically, these lenses work by extending or elongating the focal point to enhance our depth of focus. And there's really three types of extended depth of focus IOLs. There's the small aperture, which are things like the Aptera IC8 and extra focus lens. There's the EDOF lenses like the Vivity and Symphony IOLs, for example. And then there's enhanced monofocals like the iHance and Ray 1 lenses that are available. And there are many others as well. Most of these lenses do come in a toric power. And basically, there's been shown to be quite a bit of, there's relatively high patient satisfaction with the use of these lenses. So let's look at a case. This is a 48-year-old woman who was interested in refractive surgery for professional public appearance reasons. You can see she's quite hyperopic with a significant amount of astigmatism in each eye. And these are her keratometry here, which match her astigmatism. So topic pupil size is 5 millimeters, and pachymetry is good, and she was left eye dominant. We reviewed options, obviously not a great candidate for laser vision correction, possibly a phakic IOL candidate, but we don't have that available in the US, and maybe a toric IOL or extended depth of focus lens with blended vision. So she did have refractive lens exchange with these extended depth IOLs with limbo relaxing incisions, and you can see the power here is quite high. Here we're performing the limbo relaxing incisions before we start the case on each side. And then once that's done, the cataract's removed and the lens is placed inside the eye and aligned appropriately. And this patient ended up doing very well with this approach. And here we can see the results. At 1 week, she was 20/25 plus in both eyes and J2 as well. So very satisfied with this result for her situation. So you have to be careful because if you get it wrong, it could be potentially lethal. You might remember these Samsung phones that were exploding. And so this brings us to our question. First question, which of the following statements are true? Workup for new technology IOLs is the same as that for standard monofocal IOLs. Any biometry is sufficient for calculating IOL power for new technology IOL. Corneal topography is necessary for using toric IOLs. Or IOL formulas are interchangeable with optical biometry when using new technology IOLs. Excellent. So I see most of you got the point. And really today with new technology or advanced technology IOLs, corneal topography has really become the standard for using these lenses. So obviously, the best prevention is avoidance, and that means understanding which patients are maybe not good candidates for some of these advanced technology or presbyopic technology IOLs. And I think patients with moderate to severe dry eye are not ideal candidates. Patients with bad or uncontrolled blepharitis, that either needs to be managed and sustained, or it's just best to avoid placement of IOLs in those patients. Patients, obviously, with corneal opacities or guttata don't do well with these. And patients with particularly small pupils or large irregular pupils are also patients to avoid with presbyopic IOLs. Any kind of macular pathology. For many patients, if you're considering a advanced technology IOL, it's best to get a macular OCT to verify normal foveal and macular anatomy. Basically patients with extreme refractive situations, maybe being extremely myopic or extremely nearsighted, especially for the novice cataract surgeon, it's best to avoid those patients. Measuring patients with high angle kappa, where there's a displacement of the pupillary and visual axis. We have a lot of rigid gas permeable contact lens wearers, at least in my area in the United States. These patients need to be out of their contact lenses for 3 to 4 weeks, sometimes longer. You have to understand that rigid gas permeable contact lens wearers really have very sharp vision because all their aberrations and irregularities are essentially neutralized by the contact lens. They're used to very crisp, clear vision. And when they don't achieve this with an intraocular lens implant, they actually are quite upset. So as a general rule, I like to avoid presbyopic lenses in these particular patients. Lastly, I think as I mentioned before, it's important to understand what people's recreational and professional interests are. And I'll perform a lot of intraocular lens exchanges for unhappy post-cataract patients. And there's really three groups of people who I think do not, I do not recommend multifocal or presbyopic technology IOLs. And those are for photographers, artists, and people who bird watch. Now, these may all seem like, um, in a way, obvious, but I have a disproportionate number of these groups of patients who are very unhappy with their presbyopic IOLs. So I think it's also important to understand lifestyle and lens choice. I think uh, I think patients who are low myopes, those are patients who are used to reading without glasses. They actually are not very happy with multifocal IOLs in general and really may be disappointed with their near new vision. If you ask patients, do you take your glasses off to read in bed at night? And they say yes. They'll want the same quality of vision after their cataract surgery. And you really have to counsel these patients that the near vision is going to be different, and you have to stress that they're going to get improved uh, distance vision and they'll have improved overall functioning, but their near vision is not going to be the same as it was now. And for a lot of patients, they don't want to give that up. So it's important to highlight that. Secondly, if you have patients who are working in dim light situations, these patients are going to need better reading vision in dim light. Certain IOLs, such as the Technis multifocal, may be better because this particular lens is pupil independent, where other diffractive optics may be a problem if the patient has a large resting pupil. The optic may be better at the distance and less effective at near. So sometimes for these patients, again, it's important to understand what their needs are, and maybe an accommodative lens or an enhanced monofocal lens might have advantages in low light situations and not affect the light level as well. We all know that diffractive optics do reduce contrast sensitivity, and this is another issue for low light working environments. Obviously, certain professions, such as people who drive at night or pilots, these patients are usually not good candidates for multifocal IOLs. There's halos with these types of IOLs, particularly diffractive multifocal IOLs. And again, best to just avoid those lenses. And actually, in some countries, these lenses are not allowed to be placed in pilots. For optical issues. So again, you may need to choose a different type of IOL for these patients. Sometimes you can, if patients really want a multifocal lens, we suggest a monofocal or EDOF lens, maybe in the dominant eye with a multifocal lens in the non-dominant eye. And I do this a lot for patients who I'm worried about compromised vision. So it's also important to understand patients' preferences. So, there's a lot of patients who don't like bifocals for various reasons. They, for example, may never have been able to adopt to a progressive lens or glasses, and they'd rather have two separate pair of glasses. These are patients who have demonstrated difficulty in adapting to their visual system. And again, best to avoid multifocal lenses in these patients. And again, patients who are monofocal contact lens wearers, they tend to be halophobic or glare-phobic, and again, probably best to avoid diffractive multifocal in these patients. Obviously, if patients are successful multifocal contact lens wearers, those patients may be good candidates for multifocal IOLs as they've shown adaptability and plasticity in their visual system. But if patients trial multifocals and fail, it's not necessarily a good reflection that they'll not tolerate that. You have to remember that multifocal lenses, many times they shift and move, which IOLs do not do that. And we don't have to worry so much about ocular surface hydration with those issues. Typically, patients who have monovision or contact lens monovision who have done very well, this is another group of patients where I've had to explant IOLs from because they did not tolerate the quality of vision and they wanted their monovision back. So if people have had successful monovision, you really want to keep them in that and just essentially duplicate that for them when they have their cataract surgery. So obviously there could be medical or optical situations that affect the choice of the surgeon's lens choice, IOL choice, and previous refractive surgery. Obviously, those patients, it's very hard to put in multifocal IOLs in those patients because of the induced aberrations. Unless you have the information, no, they were very low treatment with a large optical zone, I would definitely avoid multifocal IOLs. And also patients that have had hyperopic correction, these patients already have an induced hyperprolate cornea and already have an extended depth of focus. So multifocal lenses should be avoided in hyperopic post-refractive patients as well. We also do not recommend patients who have had previous radiokeratotomy to have any kind of diffractive optics. We know that RK already reduces contrast sensitivity, and it's best to use like a neutral aspheric lens implant, potentially a light adjustable lens or something like the Aptera IC8, which is a small aperture optic. Obviously, if you're considering a multifocal IOL, we know corneal topography really is a must these days to look at corneal symmetry and irregularity, but you need to consider aberrometry too. And, if patients have a lot of aberrations, multifocal lenses probably are not a good choice for them. And, even the correction of regular astigmatism with laser vision correction or limbo relaxing incisions can induce some irregular astigmatism affecting multifocal performance. Again, I already mentioned dry eyes, and this really needs to be treated preoperatively and sustained afterwards. We know that dry eyes do reduce contrast sensitivity as well in these patients. Obviously, patients with moderate or advanced glaucoma should avoid multifocal IOLs due to contrast compromise, but accommodative IOLs could be an option for these patients. And for early to moderate glaucoma, you could consider a multifocal lens for the motivated patient, but you should have a long discussion with those patients about that. Obviously, pupillometry now becomes an important issue, and this is relevant for the effect of pupil size on increased depth of focus. Again, patients with large pupils don't benefit as much from a diffractive-centered multifocal lens. And patients with large pupils under relatively bright light conditions tend to do better with certain types of multifocals, as I mentioned before, where the diffractive optics extend out to the periphery, such as the Technis multifocal. As I mentioned before, angle kappa becomes and angle alpha becomes an issue. Patients with a high angle kappa really are not good candidates for multifocal. The cutoff is variable, but in one study it showed if it was greater than 0.43 millimeters, that a multifocal lens was not recommended. So what about patients that have a unilateral cataract or had previous cataract with a monofocal lens? Well, interestingly, most of these patients do very well with multifocal lenses or extended depth of focus. They just don't receive the full benefit of the lens implant. And these the previous eye should be close to plano and ideally be the dominant eye. But you can certainly switch dominance sometimes for these patients. Again, it's just having the right kind of conversation with them about the situation. And again, if a patient has a monofocal lens in one eye, the kind of complaints about halo or glare tend to be less as the monofocal eye tends to suppress a lot of the side effects for the patient in the other eye. So oftentimes we're asked, what goes in the second eye? Well, people often mix and match, and sometimes people will do an extended depth of focus in the dominant eye and a multifocal in the non-dominant eye. I do think when you're starting using multifocal lenses, it's good to wait a week or two between surgery, really to appreciate how the patient's adapting, and you can adjust the calculation also for the second eye. If you end up being a little off, you can sometimes tweak the adjustment for the second eye, which is quite helpful. For new technology, IOLs, again, getting optical biometry is important. Using the latest formulas. This is, I think with the availability of online calculators now, there's no excuse for using old formulas that are 25, 30 years old. Kane, Barrett, Olson, Hill RBF 2.0, and the new ESCRS IOL calculator are all available and easy to use. I do suggest when you use new technology lenses that you use two formulas for all premium lenses. I like that. For that reason, I like using the ESCRS calculator because it gives you uh, um, 5 or 6 options with the latest formulas, some of which are AI based. And I also like, the biggest reason we have errors now with IOLs is not axial length, it's keratometry. So you really want to verify keratometry on at least 2 devices to make sure that it's accurate. Um, I can't tell you the number of times where I looked at the optical biometry, keratometry, and have compared it with my Pentacam, my Auto Ks, and they're off. And I have them repeat it. And so you want to always verify keratometry, at least with 2 sources. Again, when using these extended depth of focus lenses or multifocals in particular, some lenses are more, it's better to target the first plus. Others, it's better to target the first minus. So please talk with your reps from the companies to see what they recommend, or for experienced colleagues who can tell you what the best target is. Sometimes it's a little plus, sometimes it's a little minus, sometimes it's closest to plano. So you really have to understand what the best target is for the best result. Blended vision works very well, particularly with EDOF lenses. And again, this is something where it's usually somewhere between -75 and -1. It can be more, it could be a little less, but again, talk with your reps and talk with your senior colleagues. Again, just to mention the IOL formulas, the Barrett Universal 2 seems to always rise to the top as one of the best formulas overall. And this is just a study from 2017 looking at that. But, again, using any of the new modern formulas is going to be very helpful for you in getting the most accurate calculations. And the Barrett is available online for use. So, what about intraoperative considerations with new technology IOLs? Well, obviously, it's good to perform topical anesthesia for these cases because we often need to have the patient, particularly at the end, fixate on the microscope light to make sure that our lens is well centered over the visual axis so that we get the best results possible. We know that if these lenses are decentered, that it will reduce the quality of vision and create more aberrations for the patient. We want to make sure there's a low residual astigmatism after the surgery. And if we're using toric IOLs, marking techniques or intraoperative, aberrometry is relevant. And we like to keep the capsule rhexis size, maybe within the 5 to 5.5 millimeter range to provide a good effective lens position for the IOL. This is a nice algorithm from Dr. Mitchell Weichert, and it really talks about how we choose lenses for patients. Everyone gets the same discussion, and regarding the IOLs available, we look at the ocular status and review the visual goals for the patient. How much does the patient want spectacle independence? How are the eyes doing? Are they in good shape? And then whether the patient needs a toric or non-toric lens, and concerns about halo tolerance. If it's no, then the patient gets a multifocal lens. If there are concerns, you might consider moving to a extended depth of focus lens. And then, evaluating whether the patient's happy with the first eye or not. And if they're not, you can do a mix and match approach. You can consider a mini monovision, or you can, place a similar lens in the other eye. And I think all of that is very, very useful exercise when you're talking to patients. And it becomes very easy once you kind of implement this into your um, system. So this is just a case of a patient who really was unhappy with their lens, and they wanted extended depth of focus lens, and they wanted their astigmatism corrected. So this patient we actually took out what seemed like a very excellent result here with this monofocal lens surgically, but the patient was unhappy visually with the quality of their lens. And so, as you can see, there's not a lot of fibrosis in this case. I don't recall exactly how long this was after the original surgery. Not long, I think months maybe. And we were able to, nicely remove this um, lens from the eye. You can see there's a little bit of fibrosis here. Uh, and exchange it for a toric extended depth of focus lens, for which the patient was very, very pleased with the results. So I do think it's important that if a patient really wants a certain kind of visual outcome and needs a specific kind of lens, and you don't offer that, that you refer the patient to a more experienced surgeon to do that. This is just a technique I use for refolding the lens inside the eye and removing it. I now have developed some special tools to do this, but this works very well. Here we're putting in a Technis Symphony toric lens for this patient, and being very happy with the results. So let's go to question two. Question two is which of the following statements is false? Working in dim light doesn't affect the performance of multifocal IOLs. Presbyopic IOLs can be placed in only one eye. Patients with previous successful contact lens monovision should not have bilateral multifocal IOLs. And multifocal IOLs should not be used in patients who don't tolerate progressive lenses. Great. So yeah, so basically, number one is the false statement. Working in dim light doesn't affect the performance of multifocal IOLs. In general, it depends on the type of multifocal IOLs, but because multifocal diffractive lenses reduce contrast sensitivity, it does affect the ability to see well in dim light. That might also be a function of pupil size, depending on the size of depending on the type of diffractive optic that you're using. So I want to move on to surgical management of astigmatism and cataract surgery. I'm going to kind of move quickly through this for time's sake. So as we already mentioned, patient expectations are high. Patients with astigmatism now have several options, and treating that astigmatism is necessary for patients really just desiring presbyopic IOLs. So, just looking at US demographics, we can see in the US, we perform about 3.7 million cataract surgeries a year. And uh, basically, about 25% of the population has between 1 to 2 diopters of astigmatism, and about 10% have more than 2 diopters of astigmatism. So, management of astigmatism comes in many forms. You can do on-axis cataract incisions, which is a way of correcting very small amounts of astigmatism, but you can also do corneal and limbal relaxing incisions, either using manually or using a laser. There's toric IOLs, and of course, there's laser vision correction, or you can use any combination of these to manage the astigmatism. So I think one of the biggest issues in treating astigmatism is the evaluation of astigmatism. Why does the patient have this? And really, good surgical results start with proper preoperative evaluation. So you need to screen patients for pathologic astigmatism. We know there's many reasons people can have astigmatism, including dry eye, anterior basement membrane dystrophy, Salzmann's degeneration, pterygia, and then conditions like Terriens, marginal degeneration, or people have form-fruste keratoconus, pellucid, furrow degeneration, and patients that have contact lens wear can have significant molding of their corneas. So although, you can get manual keratometry and use Placido discs, which are helpful, you really need corneal topography if you're planning surgical treatment of astigmatism, and you need to make sure the patients have a healthy ocular surface. So, with on-axis cataract incisions, you're always placing the incision on the steep axis to reduce the pre-existing corneal astigmatism. And, this is particularly beneficial if you're making a larger incision. And basically, what's great about this is it's very easy and safe to do, and it doesn't really require any new skills or instruments. And it can be used to supplement limbal relaxing incisions or peripheral corneal relaxing incisions, as well as toric IOLs. So this is just some data showing the effect or how much you can treat with a scleral tunnel versus something like a clear corneal incision. And most of us are operating in the sub 3.5 millimeter range, and some of us are down to even 2.2, which doesn't induce much astigmatism at all. So if you're wondering how much astigmatism you're inducing, you can go to Warren Hill's website here at www.dr-hill.com, and there's a nice surgically induced astigmatism calculator there. It basically uses vector analysis to determine surgically induced astigmatism. You do need to register, but it is free. So let's talk about limbal relaxing incisions or corneal relaxing incisions. These are simple. They correct the astigmatism at the source in the cornea. They're inexpensive, easy to perform. The incisions don't rotate like a toric IOL might. They're performed at the time of surgery. They can be repeated, and there's really minimal impact on healing if you're doing this in a normal cornea. The disadvantages is that it does require corneal topography. There always is a risk of perforation when performing these, and they are less precise than laser vision correction or toric IOLs, and they potentially can be irritating for the patient based on location and ocular anatomy. So these can correct, usually I use these to correct about 1.5 or definitely less than 2 diopters of astigmatism. Um, and, they can be combined when you have very high astigmatism beyond what a toric IOL can do. They can also correct non-orthogonal astigmatism, which a toric IOL cannot do. And they can be used, for example, if you have a posterior capsular tear, rupture, and you still want to correct some of the IOL if you have to place a three-piece in the sulcus or with optic capture or something like that. These incisions are usually about 70–80% depth. They're placed in front of the limbus on the steep meridian. Again, you don't need to do pachymetry. They heal faster than, say, more central incisions like arcuokeratotomy, and they provide quick refractive stabilization. And there's also, because they're more peripheral, they induce less irregular astigmatism and glare than the standard arcuokeratotomy. We basically, you want to mark these like you would a toric lens, with the patient sitting up, both eyes open, looking forward. And you want to place the LRIs usually at the beginning. You can place them anytime, but most people place them at the beginning when the eye is not so soft. It's much easier to perform. And you calculate, what's nice about this is you calculate the IOL power as usual. There's no change in the keratometry with this procedure. So the coupling ratio is 1:1. And so you can just do your standard calculation. We always mark on the steep corneal axis, as I already mentioned, and then usually just make a reference mark here. You can use degrees or millimeters depending on the nomogram you're using. The general rule is every millimeter is equivalent to 10 degrees. So that's a very simple method. And usually this is made with a preset blade, whether it's a metal or diamond blade of about 500 to 600 microns in depth. And basically, they come in many flavors here. I won't spend a lot of time, but there's preset metal blades you can use. A lot of people use gem blades. They use this for a long time, a sapphire blade. They can, you buy it. It's much less expensive than a diamond blade and can be used for hundreds of cases. And Ryan and Hugo made, ones that were about $250 versus diamonds, which obviously last the longest, but are most expensive at around $2,000 on average. So there's a lot of nomograms out there. This is one that was popularized by Jim Gill in the 90s. It's a good starter, but I much prefer something like this. Dr. Paul Koch used the term peripheral corneal relaxing incisions, which I like more because you actually want your incisions to be inside the limbus, not on the limbus. And these correct, again, they're using degrees, and they have a nice adjustment for age as well. This is one of the more, I think, predictable nomograms that I use today. So in the US, we have this website, www.lricalculator.com. I don't believe it works outside the US, but it's very nice for calculating that. It's developed by Eric Donenfeld, and you can print this out and bring it to the operating room. And there's also another calculator on which you can get through iTube as well for calculating astigmatism management. Here's just a LRI. We're just marking again the location and measuring. Again, remember I said 1 millimeter is about 10 degrees, and just use this to mark both sides. And again, we're using a steel blade preset 600 microns, and we make that on both sides. And then once that's done, this is done at the beginning of the surgery. This is following the calculator, and then we just go about and do our surgery. So obviously nothing is free of complications. I think the biggest mistake is incising the wrong axis, and I've seen that happen before. You really want to make sure you're on the steep axis with these. Obviously, you can suture these incisions. You can add additional incisions, and you can do laser vision correction to correct that. Wound gape is particularly an issue in certain cases, particularly if the incision's very long. Sometimes we see that more commonly with steel blades or non-perpendicular incisions. or if there's excessive wound manipulation. You can get undercorrections if the incisions are too shallow or too peripheral, and micro and macro perforations are possible but very infrequent. And here you can obviously resuture those if you do have a macro perforation. Micro perforations usually don't cause a problem. So obviously we have toric IOLs. There's many different flavors of these, and I'm not going to focus on any specific ones. It basically toric IOLs, they correct two refractive issues, both sphere and cylinder, and they are more accurate and stable than limbo relaxing incisions. And the main theoretical disadvantage is you're correcting, corneal astigmatism inside the eye. But these lenses have been out for, over 20 years now. And the first one's being released, I think, in 1998. And it's important to understand that toric IOLs correct less astigmatism because the correction is intraocular and not on the cornea. So the equivalent is one diopter of corneal astigmatism is about 1.41 diopters of IOL astigmatism. So we're going to get, if we're correcting 3 diopters or 2.8 diopters of IOL astigmatism, we're only getting 2 diopters of corneal astigmatism. So, the surgical considerations here, you're performing standard cataract surgery, but it does require some variation for the toric lenses. We have the IOL calculation, which determines the spherical power. We have to mark the axis, mark the eye, and then we have to align the IOL. So it's important to understand in general how often eyes rotate. The study looking at 240 eyes compared alignment sitting up versus lying down. And in general, they found that difference is about 4 degrees of misalignment. And then in 8% of these patients, the eye rotated more than 10 degrees. And of course, if you do not compensate for that, you're going to lose the effectiveness of the toric lens implant that you place. So basically, for every degree that you're off, you're going to lose 3.3 degrees in effect. So if you're off by 4 degrees, you're losing about 14%. If you're off 10 degrees, you're losing a third of the effect of the toric lens. And if you're more than 30 degrees off, you're going to have no effect at all. And more than that is just going to increase the astigmatism. So we have reference markers that we use for these cases. Usually we do this with the patient in the sitting position and placed at the limbus in 2 to 3 locations. And then we intraoperatively will mark the patient for the alignment of the IOL and using those pre-op reference marks for alignment. So most of us, we can do this manually, but another app that I really like is the ToriCam app. This was developed by Graham Barrett. And basically, you mark the limbus what you perceive is to be the 0-180 mark, and then you use the ToriCam to align the red reference mark to the limbus and see how off you are. And this is stored in the iPhone. I don't know if it's available on other apps, but this records the reference axis, patient's name, date, time of the image. And you can see here's the difference for the reference mark after taking the photo, saying that it was off by 7 degrees, and I can compensate for that when I mark the patient. So again, when you're placing the toric IOL, there's really 3 steps to the procedure for the IOL insertion. It's a gross alignment, which is about 15 to 20 degrees short of the desired position, removal of the OVD, and you need to stabilize the IOL during OVD removal or it's going to rotate, and then final alignment to the intended axis. So here we have the marks and the toric marker you can see circled here. Here's we placing the lens, and here's our axis marks over here. It's off by about 15 to 10 degrees. And then we basically hold the lens down while we remove the OVD. And then we go ahead and do that final minor adjustment to get the lens perfectly aligned. So again, sometimes that can be difficult. Some people, if you have a silicone sleeve, you can suction, you can use your IA and suction onto the IOL and remove it. You can use a little device called like the Sonnenfeld irrigating positioner or dip with bimanual irrigation. And all of this works very well to get the lens in place. This is just using the Sonnenfeld irrigating positioner after its end to get the lens finally removed. And it's just placed through the wound, and it provides enough irrigation and um, deepening of the capsular bag to allow the IOL to be gently moved into proper position. So, in today's world, we have digital markers now built into some of these microscopes and guidance systems. So, if you have access to this, congratulations, I do not. And, this obviously will make things very accurate for you when you place that. Um, the Callisto is another system by Zeiss that's also used for alignment, and it, pairs with specifically with the scope so that you can make sure that your marks are aligned. And, in terms of toric IOLs, Elcon, well, actually Bausch and Lomb, no, Star was the first one to come out with a toric IOL in 1998, but we didn't really gain much traction because it was a plate IOL. But the Acrosoft toric lens from Elcon really kind of broke through the ceiling on that, and it comes in a wide range of power. Remember, the lens may go up to like a 6 for the IOL plane, but really only correcting about 4 in the cornea. And they have the online calculators for this, which I'm sure you're all familiar with, that you can program. And, basically these lenses have been shown to be quite stable for the most part. And really only a very small percentage of these experienced any kind of significant rotation loss. Probably the biggest thing is for eyes with very long axial lengths. There's been shown to be a higher incidence of rotation. So many people place a CTR for these longer axial length eyes to help stabilize the toric lens when it goes into place and minimize rotation. The Tecnis AMO, I'm sorry, Tecnis J&J Tecnis toric lens was approved several years later, and it also works quite well. It's undergone 2 iterations, but also corrects a similar amount of astigmatism. Sometimes if you find the patient has the astigmatisms don't line up, you can use this online calculator about repositioning after cataract surgery with the toric IOL with astigmatismfix.com. And basically, you enter the data, what you expected, what the refraction is, what lens you used, and it'll tell you how to reposition the lens. We also have intraoperative aberrometry with the Alcon Verify system or Aura. And basically, this really eliminates the need for preoperative biometry and keratometry for the IOL power, and it'll tell you when it's lined up correctly so we can get the correct IOL power on the table for more accuracy. And that's been shown to be the case in several studies. So obviously, when to avoid toric IOLs, if you have zonular dehiscence, you have significant pseudoexfoliation or weakened zonules, in cases such as a white cataract or uveitic cataract, if you have a posterior capsular tear, disruption, and when patients have had prior intraocular surgery, that can also be a problem. But this is essentially my stepladder approach to cataract surgical astigmatism. Patients have less than a diopter. We're typically doing on-axis astigmatism incisions with a mini limbal relaxing incision for 1 to 1.5, maybe LRIs or a toric lens, or maybe laser vision correction if there's issues afterwards. For higher corrections, toric lenses or laser vision correction. And then for more than four, we're combining different technologies such as toric IOLs with limbal relaxing incisions or laser vision correction. So in conclusion, both limbal relaxing incisions and toric IOLs are important for addressing astigmatism in cataract patients. Incisional techniques can be used alone with monofocal or presbyopic IOLs or with toric IOLs. And toric IOLs are becoming increasingly important, but require careful preoperative and intraoperative considerations. And toric IOLs are a great way to enter the refractive IOL market if you're, not comfortable putting in multifocal IOLs. But really, surgeons need to be familiar with both of these, all of these technologies, but it does require more time both for the surgeon and the staff. And in general, new technology IOLs offer many advantages over monofocal lenses, but choosing correct IOLs require extra preoperative screening, patient considerations, accurate biometry, and modern IOL formulas to ensure patient satisfaction. Managing astigmatism, as I said, is essential, and patient selection and education are also essential. So you can do it. And thank you very much for your attention. We have a question about the ideal pupil size for multifocal IOL implantation. I think that would be somewhere between no smaller than 2.5 millimeters and probably no bigger than like 5 millimeters. Like as an overall answer. So again, it really depends on the type of diffractive multifocal IOL you're using. But some are more distant dominant, some are more near dominant. And again, if you're dealing with a very small pupil or a very large pupil, I think you have to be you have to pay a lot of attention to the specific design of the multifocal IOL you want to use. Another question is what might be the cause if a person complains of night difficulty vision after an EDOF IOL implantation? So I think that probably has a lot to do with the target of the EDOF. So some of the EDOFs, have smaller and larger amounts of effect and extending the depth of focus. Um, and I think in general, we have the Purkinje effect where there's a shift towards seeing blue light, shorter wavelengths of light, and patients actually becoming more nearsighted in dim light, and the pupil dilating. And all of those can have effects on that target. So I do think that that's something that you need to be aware of. Um, Another question is, have you ever used or would you recommend the Ladas formula? So I don't have any personal experience with the Ladas formula. I know it uses a very interesting algorithm to calculate the IOL power. I don't have enough experience to talk about it extensively. I have heard fairly good things about the formula, but I don't have any experience using it now. Um, I would recommend, again, using multiple formulas to kind of get a consensus on what is the best choice for the advanced technology IOL. And of course, someone asked if these modern formulas also benefit current monofocal IOL calculations, or just for new IOLs. And I think the answer is they benefit everyone. So I think there is um, plenty of options. I mean, I think we should all be using new IOL formulas. Some of them incorporate AI, some of them are hybrid. But they all are essentially, an improvement over the older standard IOLs, such as the SRK2, Hoffer Q, SRKT. I mean, these are, of course, you can use them, but we all have access online essentially now and should be able to use the more modern formulas. It's just also important to make sure you're using the right A constants, whether it's for optical biometry or ultrasound, when you're doing these calculations. Um, Another person asked, is there a multifocal or EDOF lens that steps up in quarter diopters to have more accuracy? And the answer is I think so. Not available in the US. We have, I think Hoya has one that goes up in quarter diopter steps. Again, not extensively used in the US. Um, but that's a very good point, in that, we have to round up or round down a lot of times because we have most of the IOLs only come in half diopter steps. So this is very important. And also it's important to tell the patient if, they end up in the middle and you have to round up or round down. So again, this is where multiple formulas can be helpful, to help you decide the best choice, and that may be rounding more up or round down if they're in the middle. Um, if the emmetropic, another question is, so if the emmetropic target is on 20.25 with a Barrett 2 formula, which EDOF would you choose and why? I think I have the most experience with Symphony, the Johnson and Johnson Technis line. Um, in general, again, it kind of depends if the patient wants more distant or near. You just have to tell them that, again, for EDOFs, I tend to target the first minus in general. Um, Multifocals, depending on the lens, I'm going to target potentially the first plus. Uh, the new Technis Odyssey lens, I do choose the first minus so they have sufficient reading. But again, it really depends on what your specific multifocal lens is, and why you would, and then you need to have that conversation with the patient. And then it says, the other question is for us, ophthalmologists and cataract surgeons, which IOL would you yourself choose if you were to have cataract surgery? So I personally feel like I want the best quality vision more than range of vision. So for me, having a intraocular lens that has good optic material, that has a long-standing track record of clarity, and a lens that has a low, um, kind of a higher Abbey score, and um, would be important to me. I think blended vision is a great option. And maybe I would choose a EDOF lens in one eye. So, so there's a few other questions here. One is correcting high cylinder number after cataract surgery or pre-cataract surgery with LASIK. Which option would you think? Well, I think astigmatism can be corrected very well with LASIK surgery. Again, once you get to about 4 diopters of corneal astigmatism, you're going to have to combine it with another technology. Or you may have to have the discussion with the patient that we can correct 4 of your 5 diopters, but you're still going to have 1 diopter left. Or if they have 6 diopters, they're going to have 2 diopters left. You can try to correct some of it with limbal relaxing incisions, but that's really going to depend. Yeah, laser vision correction is a great way to correct any residual astigmatism that can't be corrected with a lens implant. And maybe the patient has like form fruits keratoconus. You're not going to do incisions on those patients. You're probably not going to do laser vision correction, so you're going to have to rely on the toric lens for that. Another question: when you implant a toric, do you clean the endothelial cells under the anterior capsule or not? That's interesting. Some patients say don't, to trap the IOL to make it less rot. I've not found that to be the case. I clean every case under the anterior capsule. I've seen too many cases of capsular phimosis, which cause a lot more damage than the lens rotating. Again, I think most of the literature supports the use of a capsular tension ring for long axial length, but I've not seen any papers specifically addressing that. Um, Another question is, how would you adjust IOL power for corneal astigmatism measured? Well, that's one of the nice things about toric lenses is that you just have to calculate the spherical measurement, and then you have to go to one of the IOL toric calculators in order to determine the IOL needed, toric IOL needed to correct the specific amount of astigmatism. So you would just do your normal calculation. Some of the online calculators do have a toric option that you can utilize as well. So I think you can either just use your standard biometry and then go to the online calculator, or you can go to one of the online calculators that include the toric calculation as part of the data entry. And interesting. So another person asked about if EDOFs can be used in MSIGs. So I guess I would say it really depends on I would say yes, especially if you're doing a small MSIGs. You're going to have a little bit of induced astigmatism, but I think EDOFs are they're very accommodating to these issues where obviously multifocal would not. But yeah, I mean, again, I don't have a lot of experience doing that, but I do think it is definitely potentially an option. Another person asked, does implanting one eye with EDOF and one eye with a multifocal reduce halo and glare? The answer is definitely yes. I just did a recent evaluation of the past 5 years. I did over 300 IOL exchanges. A third of them were for multifocal lenses that patients were not happy with. And I usually start off with the dominant eye for the patient, and I exchange it for either a EDOF or just a standard monofocal lens. And 50% of the patients are happy with that because it greatly reduces night halos and glare. So I would say yes, it definitely reduces. Some people still want the other eye done, but a lot of people are very happy with that as a solution. Another person asked, do you have a preference of using multifocal lenses based on gender, female or male? Hmm. Hmm. I think there might be a cultural context to this that would vary from country to country. Specifically based on gender, I can't say that I do. As I mentioned before, the photographers, artists, and bird watchers seem to be people who care a lot. So I would say occupation has probably more of an influence than gender. Um, what should be done if a PCR happens? Well, as I mentioned before, it depends. Obviously, if you have a multifocal lens, they do make a few three-piece multifocal lenses. Most of them have been discontinued. I personally think this is a discussion you have to have preoperatively with the patient to say, a multifocal lens or a toric IOL requires everything to be perfect. And if it's not perfect, then we're not going to be able to put that lens in. So I do talk about that with patients. To say this specific lens requires everything to be perfect, and if it's not perfect, we're not going to put it in. Again, I can't tell you the number of patients I've had to go and remove dislocated, subluxed, advanced technology lenses because patients put them in in compromised situations. So I think it's better to tell patients up front. What we say is, if you tell the patient about it before the surgery, you're giving them information. If you tell them after the surgery, you're creating an excuse. So best to tell the patient these things up front. Um, and let's see. The next person asked, "What is your opinion about the real clinical impact of the differences in Abbey number and of multi-IOL materials?" So, I think index of refraction does play a role in multifocal lens materials. Um, I don't have the Abbey number offhand, but I do worry about, high index of refraction materials have a much higher total internal reflection, which, may for some patients, create more optical aberrations for them, like positive dysphotopsias. So again, I think there's no way to guarantee that patients are not potentially going to have these kind of issues, but I do think that we can choose lens multifocal lenses that have lower index of refraction material. So it's a good to know, what those numbers are for the lens implants you're using. What is my favorite IOL for normal high myopes and high hyperopes? Well, I would say for that, I would say my favorite IOL is a monofocal IOL. Well, for high myopes, sometimes, once if they're very myopic, you only have a choice of monofocal IOLs. I mean, I personally, for patients that, require like a minus power IOL or like a low plus power IOL, I do use the Johnson & Johnson AR40E Sensor lens because it goes all the way down to -10. And usually I find it's optically stays very clear and it has a rounded anterior edge, which I like. For high hyperopes, I guess, well, again, it really depends on the power. So we're limited. Many of the lenses stop at plus 34. This is where there's an Elcon lens that goes up to plus 40, and depending on where you are in the world, you can customize these lenses up to plus 60 or something like this. So I tend to use the Technis ZC Boo lens, which goes up to plus 34, I believe. And then I use the CT Lucia lens because of its A constant will go a little bit higher. And then beyond that, I'm only left in the US with the Elcon Acrosoft SA60 AT, which goes up to plus 40. So that we have limited options, but that's the best I think I can answer that question. Um, so someone asked about which multifocal is the most accurate. I think this really depends a lot on your preoperative information. So they asked, so a toric multifocal. Again, I think if it really depends on which lens you're using. Some of the lenses require extreme accuracy and don't have a very gentle, don't have a wide range of leniency. So in general, I don't. I think you really have to be familiar with that. I think I want the multifocal lens that gives me the most flexibility, not necessarily the most accurate. So, again, I think some of the new lenses are, they've modified the surfaces enough to reduce some of the side effects. They've made the central zone a little bit larger. things like that to reduce some of the issues of the past models. And one there is no right answer for this, but I mean, obviously, the newer lenses I think provide a little bit more accuracy, and certainly the toric multifocals they have to be extra accurate because you're dealing not only with the sphere portion but also the astigmatic portion. So again, it depends. Like you may have access to a lot of Zeiss lenses that we don't have access to in the U.S. But I do think you just have to really talk with your colleagues that do a lot of these and with the reps that so you can understand the pros and cons of each multifocal lens you're using. It says, how do you handle dysphotopsias in patients with multifocal IOLs? How long should we wait until IOL exchange decision? So I would say if you ask patients in the first week about that, about positive or negative dysphotopsias, many patients will note something. Some of them obviously are very vocal. Some of them will be prompted by questioning. Usually by a month, many of these have resolved. So I usually wait about 2 months. And if there's no trend in improvement, I might consider IOL exchange after that time in a routine case. So most of these cases do improve with time, but there's certain patients where after 2 months, if things are not improving, you need to consider IOL exchange. So I usually use 2 months as a general cutoff. Maybe if it's not sure, I'll extend it to 3 months. But you do want to do the exchange, sooner rather than later because it will be a little easier. Someone asked, could EDOF lens be used in piggyback technique? I think the issue with that is that most of the EDOF lenses are not low enough powered to be used as a piggyback technique. None of them are approved for sulcus placement. They have the Rayner makes an add-on lens that you can use, but I would use a specific lens that's either been approved for sulcus placement or sulcus placement for those kind of cases. And I think for these patients, using EDOF is not the main concern for the patient. Someone asked, do you do monovision in patients with a history of myopic LASIK? Which formula would I use? So, interesting. I mentioned the ESCRS calculator. They just added PRK and LASIK on there as an option for their calculation. This happened several months ago. So I would use that formula because it'll give you several different formulas which you can compare with. But I think that's what I would use today. There's also the ASCRS post-refractive calculator, but that doesn't have, I think, as many formulas to compare with. And then someone else asked, I meant IOL formulas for high hyperopes and myopes. Let's see. In terms of IOL formulas for high hyperopes or myopes, again, I think you want to get as many IOL formulas as possible to compare. So again, I would go to the ESCRS calculator to look at the latest. They have Evo, they have all the latest formulas, Barrett, to compare side by side. And they also, what's nice about that website is they have virtually every IOL made. So you'll get the optimized A constants for that IOL. So I would recommend that. There's papers showing one formula over the other, but almost all the papers that have been done looking at multiple formulas and averaging those usually provide the best outcome, or one is always number one or two for those studies. So thank you very much. It's been a pleasure working speaking with you today, and I hope you found this presentation both educational and useful.